Up next is Dr. Andrew Lee. Dr. Andrew Lee, he's the chairman of the Department of Ophthalmology at the Methodist Hospital in Houston, Texas. And before that, he was a professor of ophthalmology, neurology, and neurosurgery at the Stanley Thompson Neuro-Ophthalmology Clinic at the University of Iowa. Some of you may have seen Dr. Lee in various conferences. He has energetic, enthusiastic style of lecturing, and I believe he was at the recent Miyako meeting in Bahrain. He has authored over 260 peer-reviewed articles and 40 book chapters and 2 full textbooks in ophthalmology, and he's in the editorial board of 12 medical journals. Dr. Lee is going to be talking about making sense of the alpha soup, this CHAMPS, ONTT, and the MS trials.
Thank you for inviting me. It's always hard to follow my friend Peter Savino, but I'll do my best. I have no financial interest or any interest in the products I'm going to discuss. So in the U.S., we have this type of soup. It's called alphabet soup because the little wheat components are made of alphabets. In the U.S., you might be familiar with some of the trials for retina in the alphabet soup, ETDRS, DRS, but we have our own alphabets in neuro-ophthalmology. The optic neuritis treatment trial, which you heard a little bit about from Peter, the ischemic optic neuropathy deconversion trial, and I'm going to talk to you about CHAMPS and ETOMS, which are MS trials, a little bit about the international trauma study for optic neuropathy, and CRASH. So my goals are to describe for you a little bit about what I think is typical and atypical about the optic neuritis treatment trial and how you should apply it in your world. And then we're going to talk about the ischemic optic neuropathy deconversion trial, the controlled high-risk AVONEX multiple sclerosis prevention study, or CHAMPS, the early treatment of MS study, and the international optic nerve trauma study and its related study, CRASH. Peter already alluded to some of this, so I'll just show you the highlights, which is the cumulative rates of recovery of visual field and optic neuritis is everybody gets better. All 3 treatment arms, as you can see here, improved, whether you receive methylprednisolone, placebo, or prednisone. So I support everything that Peter said about optic neuritis in terms of treatment versus no treatment. It shouldn't be given for visual field, and the same thing for visual acuity. Everybody gets better no matter whether you give them steroids or not. The key piece of information we learned was not to give oral steroids in conventional doses because that increased the rate of new attacks. So this is the probability of developing a recurrent optic neuritis in either eye by treatment group. And you can see the oral prednisone group, the top line there, 41% of the oral prednisone group developed a recurrent optic neuritis compared with either intravenous or placebo. In other words, in this trial, giving oral steroids harmed the patients in the conventional doses of 60 to 80 milligrams of prednisone. So either give nothing or give IV. That's the teaching point, at least in our part of the world. And this is what Peter alluded to as well, which was the cumulative probability of developing clinically definite MS, CDMS, by treatment group in the first 2 years. You can see 16.7% for placebo, 14.7% for prednisone, versus the IV group, which was less, 7.5% at year 2. Now, what I don't have on this graph is that effect wore off, as Peter mentioned, I think, at year 3 and year 5. And so this effect was not a primary outcome measure of the study, and I'm not sure what it means, but you heard some of the comments about what we think it means. And this slide is exactly the same slide as what Peter showed you. The only thing I would make mention of is 16% at year 5, no lesions, still develop MS, and you can see that trend continuing to go up and up at year 10 and year 15. The important thing is, if you have a patient with optic neuritis and they do not have any MRI lesions, no lesions, you should not tell that person they don't have MS, because 20-some% of those patients are going to develop multiple sclerosis at year 15. And the converse is also true. Even though the graph, it says 51% at 5 years, at 10 and 15 years it's much higher, and Peter showed you the number was 76%. Still, that's not 100%. So you should not tell the patient who has optic neuritis and a head full of MR lesions that they do have MS. The MR scan is prognostic for MS, but is not diagnostic for MS. So you would say, well, doesn't everybody already know this? This is from Jonathan Trobe, who performed this survey in the U.S. It published in Ophthalmology, and basically compared the practices of ophthalmologists and neurologists in the United States. And this is 7 years after publication of the trial in the New England Journal of Medicine. Both ophthalmologists and neurologist specialists, not neuro-ophthalmologists, of course, mistakenly believed the thing that Peter told you, that intravenous steroids improve spinal visual outcome. Neuro-ophthalmologists know that's not true, but ophthalmologists and neurologists in the U.S. still believe this is true. And only 7% of neurologists and 36% of the ophthalmologists were ordering an MR for the important thing, which was the message Peter gave you, which is you need it for prognostic information. So it takes about 12 years for data to leave the medical literature and enter into about half the practices in the United States. Hopefully that will no longer apply to you. Now, what's interesting also to me is worldwide there are clear differences in the application of the results of clinical trials. This is the investigations chosen by two groups of responders for optic neuritis in the UK. And you can see that for the black, that's ophthalmologists, over half of the ophthalmologists in the UK did nothing. No investigations at all. No MRI, no nothing. And 35% of the neurologists did nothing. And that's because they have a nationalized health service, and so there are clear differences in practice pattern and application of the data depending on which part of the world you are, including UK versus US, even though our demographics are almost identical in terms of the development of multiple sclerosis. This is the number of MRI scans per million population. You'll notice the United States is not number one. Japan is the number one, 35.3 MRs per million. U.S. number two, 27. And then the list drops off tremendously. But there are countries on this list that may or may not make sense to you. Canada, UK, much, much below the median for having an MR. So even if you want an MR in some of these countries, you can't get it. So clearly the things we tell you when we're standing up here may not apply in your part of the world. I don't know how many MRs you have per million in Kuwait. You have a lot, Ray? And what's curious also is this is the worldwide distribution of multiple sclerosis, and as you would expect, there's a north-south gradient, and Western Europe centered on Scandinavia, the UK, the US, and parts of Australia where the gradient is actually upside down, as you can imagine. But what's the MS rate in your part of the world? Do we really know what that is? In talking to people and traveling around, Peter and I, as he mentioned, we're in India. There's some parts of India where they just don't see MS. But there are parts of India where they see a ton of MS. So it's clear that the worldwide distribution maps of MS need to be modified based on your local climate conditions, epidemiology, patient mix. So I'm not sure if this applies to your part of the world, but this is 14 studies of MS in the Middle East. Of the 14 studies, 5 had to be excluded because of methodologic problems. The data from 9 of these studies was pooled together, and the prevalence rate varies widely in your part of the world, from low to high. The inconsistent ascertainment of the cases, the inclusion criteria, all the things you would expect from retrospective studies, calculations. But the conclusion of this study was there is little evidence to support the assertion that the prevalence of MS in the Middle East is low to medium. So we don't know, but the studies that have been done so far show you do have MS. And in talking with your local neuro-ophthalmologist, I think you do have MS here. There are a number of treatments in MS. In the U.S., we call them the ABCRs, Avonex, Betaseron, Copaxone, and Rebif. Again, I don't have any proprietary interest in this. And one of the drugs that was studied in a trial called the Controlled High-Risk Avonex Multiple Sclerosis Prevention Study, also known as CHAMPS. In this study, monosymptomatic events, optic neuritis was over half the cases, MR had to show demyelinating white matter lesions, everybody got IV steroids, and then the two arms were randomized to placebo versus interferon beta-1 alpha, which is Avonex. The primary outcome measure, development of clinically definite multiple sclerosis, and MR changes. After a 3-year pre-planned efficacy analysis, the rate of development of clinically definite MS was 45% less in the treatment arm, and all the MR parameters, number of lesions, volume of lesions, enhancement of lesions, all went down with the treatment arm compared with placebo. So this is the summary slide, which is you see the placebo in yellow here, and Avonex treatment arm here, and you can see the reduction in the rate of clinically definite MS at the pre-planned efficacy analysis at year 3 by about 45%. So in other words, if you were treated with the immunomodulatory drug, your chances of developing clinically definite MS were reduced. As Jason alluded to, though, this doesn't cure the disease. It just reduces your chance of developing it. It's delaying it, perhaps, because the curves are going to slightly catch up. This is just to show you the MR data, 67% reduction compared with placebo, the treatment arm, in the number of enhancing lesions, 91% reduction in T2 lesion volume, Percent change in T2 lesion volume under MR studies, 94% reduction. And just to show you I'm not biased towards Avonex, this is Rebif, which is also a different preparation, different dosage of interferon beta-1 alpha. Benefit was similar to CHAMPS, and even though it wasn't as robust, a significantly reduced rate of multiple sclerosis and delayed conversion to clinically definite MS, as well as reduction in the new enhancing and volume of MR lesions, same outcome measures as in CHAMPS. Now here's the flip side, and this is why Peter and I disagree a little bit about initiating therapy. I don't believe in initiating therapy unless I have proof that they have clinically definite MS, either radiographically with progression of dissemination over time radiographically, or a second lesion. 2 lesions separated in space and time. I'm kind of old school in that regard. I don't know what my colleagues think about that. But this is the average cost in US dollars per year for these drugs, and you can see this is a significant cost. I'm going to switch gears and talked about ischemic optic neuropathy decompression, the IONDT, and basically the study was very simple, looking at a surgical treatment of non-arteritic anterior ischemic optic neuropathy, surgery on the sheath versus no treatment, observation arm. And what the study showed was that surgery, at least for the typical form of non-arteritic anterior ischemic optic neuropathy, the garden variety, was not helpful, and not only that, it increased the rate of losing your vision. So surgery harmed the patients and the patients that were treated. And I can't comment to you about the progressive form of AION because this was not studied in this study, and so there's plenty of problems with this study, but at least for the garden variety ischemic optic neuropathy, non-arteritic form, we do not recommend surgery. The thing that Peter alluded to, what I learned as a resident was the same thing he learned, which is if you have an inferior altitudinal field defect, you have AION. That's clearly not true. In the optic neuritis treatment trial, you saw inferior field defects were very common, and inferior field defects were not the most common field defect in the AION observation arm of the IONDT. In addition, 45% had improvement of 2 or 3 lines of vision. I think that's very powerful information for telling the patient that there's a chance your vision will recover. And any treatment that we're going to compare has to be compared against this natural history.